quorum now?
I was a clerk. Yep.
I think we got a quorum, so. Welcome and good afternoon. Today is Tuesday, February 20th. I hereby call the Insurance Subcommittee to order. Madam Secretary, please call the roll.
Representatives Sapicki, Himmer, Hicks, Hill, Kumar, Lafferty, Martin, Mitchell, Rudd, Rudder, Terry, Chairman Haynes.
Here.
Chairman Haynes, you have a quorum.
Thank you. Before we get started, are there any personal orders? Seeing none, we have 7 bills on the calendar. First item, number 1, is House Bill 2629 by Chairman Baum. It has been rolled 1 week. Item number 2 is House Bill 1877 by Representative Freeman. It has been rolled 1 week. Item number 3 is House Bill 2903 by Chairman Kumar. It has been rolled 2 weeks. Item number 4 is House Bill 2905 by Chairman Kumar. He was here. Oh, he did. We have a proper motion and second.
Thank you, Madam Chair and members. House Bill 2903 solves a problem that it is a common feature of contracts between a tax preparation service and the Tennessee taxpayer, that if the preparation service makes a mistake on their taxes, the service will be responsible for any increase in taxes, interest, or other penalties incurred. To cover their liability about having to pay if they make a mistake, Tennessee law allows the tax preparer services to either post a surety bond or to deposit the amount of cash with the Department of Commerce and Insurance. This bill adds a third option, that they can also purchase an insurance policy so that if they make a mistake and they have a liability, the insurance policy will cover that. The insurance policy has a catchy acronym. It's called CLIP, that is Contract Liability Insurance Policy. And with that, I'll be happy to answer any questions.
Do we have any questions for the sponsor? Chairman Lafferty, you're recognized.
Thank you, Madam Chair. And it's just, I'm sure I'm just getting up to speed after lunch. Am I understanding this? If the financial professional, the tax preparer, makes a mistake, then their customer is the one that could purchase that insurance policy, or is it the provider of the services purchases an insurance policy?
Chairman Kumar.
The provider of those services will purchase a policy to cover their losses or their liabilities.
Okay. So like errors and omissions insurance, kind of. Thank you. Thank you.
Any further questions? Seeing none, we are now voting. All those in favor of sending House Bill 2905 to insurance full signify by saying aye. Aye. Opposed? The ayes have it. Bill goes to insurance full.
Thank you.
Item number 5 is House Bill 1998 by Chairman Hicks.
Motion.
We have a proper motion and second. Chairman, you're recognized on the bill.
Thank you, Madam Chair. I was getting nervous there for a second. Madam Chair, members, House Bill 1998 is about the rates we pay our ground-based ambulance services for non-emergency runs. Currently, ambulance services are paid 67.5% of the Medicaid rate for each TennCare non-emergency run, and this bill would increase that to 100%. And I stand ready to answer any questions.
Do we have any questions from the members? Seeing none, we're ready to vote. All those in favor of sending House Bill 1998 to insurance full signify by saying aye. Aye.
Aye.
Opposed? The ayes have it. Bill goes to insurance full.
Thank you, Madam Chair and Committee.
Item number 6 is House Bill 1985 by Chairman Martin.
Motion.
We have a proper motion and second. Chairman, you're recognized on the bill.
Thank you, Chair Lady and Committee. We all understand the importance of addressing our increasing access to health care across Tennessee. This is especially important to me as a rural healthcare provider. I see it in my communities every day. We are not being served adequately. The intent of this legislation is to simply make sure more Tennesseans get the service and the care they need. We have 22 counties in Tennessee, many of which are in West Tennessee, that do not have an uninsured adult safety net program or provider. And we do not have any charitable clinics in rural West Tennessee as well. Our objective is to have rural health clinics that are federally qualified, able to tap into this safety net to address the shortcomings of care. These clinics would offer sliding fee scale services, and this would not affect the behavioral health safety net fund, as it was two separate entities. But I do have testimony today, if you would mind hearing that.
Okay. With any objection, we will go out of session and hear from testimony. First up, I would like to call J.C. Werrell from Tennessee Rural Health Association. You please come forward, state your name and who you're with for the record, and you have 3 minutes.
I'm going to do a mic. Is this good?
Yes.
All right, thank you. I'm J.C. Worrell, CEO of Rural Health Association of Tennessee, a charitable nonprofit that has been advocating for rural Tennesseans and providers since 1995. RHA represents more than 800 members, including rural hospitals, clinics, federally qualified health centers, mental and behavioral health providers, school health professionals, and others. In 1977, the U.S. Congress passed Public Law 95-210, known as the Rural Health Clinic Services Act. It was established as a geographic access safety net program. Clinics in rural and medically underserved areas may volunteer to go through an extensive certifying process with the Centers for Medicare and Medicaid Services to become a safety net provider. In Tennessee, 24 counties that don't have community health centers rely on charitable and rural health clinics for primary care. This is nearly 45% of our most rural communities with no access to the uninsured adult safety net. These are counties who have the least employer options, least access to private insurance, are economically disadvantaged, and have high uninsured adult rates. The primary care providers at rural health clinics do exactly what we all say that we wish would happen more. They raise their hands after going to school. They go back to their communities and say, yes, we will serve Medicare and Medicaid patients. And some go above and beyond and implement sliding fee discount programs as a service to their community who are under and uninsured. The uninsured adult safety net is meant for uninsured individuals. The statute that authorizes the safety net makes it clear that providers' examples include, but not limited to, community health centers. We're asking to make clear that federally designated RHCs with sliding fee scales are eligible to apply because there has been inconsistent messaging over the years from Department of Health. Our bill does not make all rural health our bill does not make all clinics in rural areas eligible to apply. It does not guarantee that all rural health clinics that apply are approved. It simply recognizes RHCs as a safety net provider, the same as our U.S. government does. Thank you, and I'm happy to take any questions.
Thank you. Chairman Sapicki, you're recognized.
Thank you very much. So you representing the not-for-profits, is that the nonprofits, is that correct?
I am with a 501c3 nonprofit. Our association is a charitable organization. Our members can be any providers that care about rural health, so for-profit and nonprofit.
Chairman Sapicki.
And so this bill would increase the amount of facilities or entities that are eligible for the safety net funds. Is that correct?
Correct.
As long as
Chairman Sapicki.
they have a sliding scale. Is that correct?
Correct.
Is the money that's in the safety net a set amount?
You're recognized.
I'm not sure how to answer that. I believe so, yes. I don't understand the carry forward. So I believe the fiscal note said there was between $8 and $12 million that are carried forward each year.
Chairman Spicky.
Carry forward, probably not money that's used by the providers, right?
That's my understanding, sir.
What happens to the rural safety net if we get inundated with for-profits? Is there a difference in the care of the individual? Because the for-profit has to turn a profit versus the non-charitable are tried there for service. Is this going to create a dichotomy of two different kinds of providers?
No, sir, this just makes them eligible to apply. So they have to put forth an application, and the Department of Health will determine based on the funds available and the applications, how many patients that are being proposed be served would be accepted. So to apply to the uninsured adult safety net, you have to demonstrate need. You have to prove that you are accepting any patient using the sliding fee scale. As far as the quality of services, it is basic primary care. There's a federal statute that requires rural health clinics do not go more than 51% of primary care.
Chairman Spicky.
Do you have any data that suggests that if we would vote positive on this bill, that this will not impact the sustainability of the not-for-profits?
I don't have data. I don't think a study has been done, but again, there are 24 communities that don't have these community health centers, and it's up to the Department of Health to allocate funds based where there are uninsured people.
Chairman Spicky.
Are you aware of anything in law that prohibits more not-for-profits from being created in these rural communities?
No, sir.
And
Chairman.
and with the surplus, it would be more concerning to me up front if we had no carryover, because then we are inundated with people at our facilities. Bringing education into insurance again, we are very careful with our charters for not allowing not-for-profits because it could start to skew the educational outcomes of those not-for-profit charters. What concerns me possibly is we get into this where now these for-profits see the opportunity, they seize on the opportunity, and now because they're for profit, they could steal personnel from the nonprofits, and now we're closing our nonprofits, which are serving the altruistic need of helping people, instead of what for-profits are serving the financial part of insurance. Any comment?
I understand the concern. And again, as an advocate for rural health, I would be uncomfortable if there were not an application process that is part of approaching the safety net. So again, not all of the clinics are created equal, number one. You've got a lot of clinics in rural communities that don't want to see Medicaid patients because the reimbursement is so low. So the idea that, the safety net for seeing maybe 6%, 10% of their patients uninsured is going to be such a financial incentive that it's going to force nonprofits to close doesn't make sense to me.
And last question, Madam Chairman.
Yes.
If a for-profit is approved in this by the Department of Mental Health, because they're for-profit, can they refuse care of the indigent?
No. And it's Tennessee Department of Health has their application process, which they have to demonstrate. They, being the provider applying, has to say we have a sliding fee scale and that we will accept all patients. Now, to your earlier point, there may be circumstances where, the independent practice, because we're talking small business owner providers here, maybe they don't have all the services, but that's where they really become an important referral source to hospitals, to FQs, to specialty care providers, to mental and behavioral health, right? So we're talking about primary care services, among providers who have gone through the certifying process and then are going through an extra process with the Department of Health to say that we will see any patient that walks through our door.
Thank you, Madam Chairman.
Representative Himmer, you're recognized.
Thank you. Would you mind describing the difference between a rural health clinic and a FQHC to the committee?
I'm sure there are many. Federally, they are pretty much governed the same. Obviously, the FQs are not for profit, and the Rural Health Clinic program was established not as a charitable program, but as a geographic access program. Rural health clinics have to have a mid-level professional, nurse practitioner, PA, certified midwife, licensed clinical social worker in their buildings at any time they're seeing patients.
Representative Hemmer?
Looking at some of the federal regs, and for RHC, it lists that they're operating exclusively for the purpose of providing primary care services to Medicare patients located in rural or shortage areas. So if these patients have access to Medicare, why would they need access to the safety net funding?
So rural health clinics see Medicare and Medicaid. Many of them do see uninsured also. So they are currently certified with the state TennCare office. They see Medicaid as well.
Okay.
So we're specifically talking about uninsured individuals. And while we're talking about federal statutes, so and the nonprofits do require, or excuse me, the federal statute does require that the FQ see any patient. There's no similar statute for charitable clinics. Those policies are set independently, and rural health clinics set their policies independently as well. So again, not all of these providers are created equal. It really depends on the provider and how much of a service to their community they want to do, which is why there are incentives federally for them to establish sliding fee scales. So a clinic that establishes a sliding fee scale is eligible for the National Health Service Corps as an incentive for doing so. And we're specifically saying that we're trying to incentivize essentially these providers in these communities where there's no other care for uninsured to participate.
Thank you, Madam Chairman. You said there's no other care, but in these 22 counties that we're talking about, I'm assuming they have county health clinics, correct?
There are county health departments. Those are not created equal. I've asked the Department of Health to provide some information, and because those are all different, they're not created equal.
Recognized.
Thank you. Thank you. I understand this is a very peculiar problem. I've been trying to speak to the representative about it, and I appreciate y'all's forethought in trying to address this. And I think just some more work needs to be done to make sure these, I guess the concern I have going into this is, I'm in contact with a lot of my FQHCs that serve my area. Unfortunately, I have those, but there's only so much pool of funds, and so it's hard to make everybody held whole. So I understand the problem, and I appreciate you trying to work through it, and I'm hoping we can find a solution on this. Thank you.
Thank you.
Can I comment to that?
Yes.
So I just want to offer too that in our rural communities, they don't have access to the same grant opportunities. They don't have the foundations that are locally, like you see in Nashville and Memphis. They don't have the same support for establishing nonprofits. And so again, we're trying to help uninsured people get access to care.
Thank you.
Thank you for that. One last question thought about. I'm just going to get a presentation tomorrow about all the governor's rural health initiatives. I thought the rural health task force that was presented was very thorough, had a lot of good recommendations. I know some of the things are going to be funded toward that, but from your organization perspective, what are some of the things the governor funded in his budget for the rural health programs as outlined in that task force that are good, that we should be aware of, that help your initiatives?
I think the workforce programs are interesting. I like the proposals. I think that it is to be determined by this body how much of those dollars actually make their way to rural Tennessee.
Chairman Kumar, you're recognized.
Thank you, Madam Chair. Thank you for being here. Just a couple of basic things. What is the source of the funding for the healthcare safety net fund?
I'm not 100%. I believe it's from TennCare, but Department of Health manages it.
Okay. And so it is it is government money, and it is, as far as you know, it's from the state of Tennessee.
That's my understanding.
Okay. And you talked about um, sliding scale, and that would be that patients pay according to their income level. Is that
Correct.
true?
Correct.
That's how they pay. And on a larger question, to a patient, does it really matter if they go to a clinic that is a non-profit or for-profit? Does the patient feel a difference, or do they get charged more by for-profits?
I really think that's dependent on the provider and the local community. So I've visited a lot of rural health clinics where the patients have really good and established relationships with the provider, and they go to the provider that they think is good, cares the most about them. Maybe that is most accessible to them transportation wise. So I really think that can depend on community and provider and how they've set up their practice policies.
Thank you. Thank you, Madam Chair.
Representative Mitchell, you're recognized.
Yeah, thanks, Madam Chair. These 22 counties, how many of them have a hospital?
I would have to go digging in this computer to find that. Not many.
How many of them had a hospital that's now closed? Do you know that?
I believe we're at 12 to 14 hospital closures, depending on how you define hospital.
Okay. Committee, I think we know how to fix this problem without taking funds away from somewhere else, but we can fix it. But y'all know what the solution is. It's a few $1 billion laying on the table each year. Thanks.
Any further questions? Thank you for your testimony. We will now have Libby Thurman from the Tennessee Primary Care Association. Please state your name and who you're with for the record, please, and you have 3 minutes.
Thank you. Can you hear me?
Yes.
Thank you for the opportunity to speak with you today. I'm Libby Thurman, CEO of the Tennessee Primary Care Association. We are the membership association for federally qualified health centers across the state of Tennessee. We have 30 organizational members. They do have more than one site each, though, so you're looking at about 150 to 175 sites across the state. And a couple of hallmarks of the FQHC program is that health centers do see everyone who comes in their doors. It doesn't matter if you have insurance or if you don't, they're going to see you the same. And it doesn't matter your income level. So that is really the hallmark, is we take anyone who comes in. And then also each of those individuals receives the same level of care. And then in terms of a sliding scale, federally qualified health centers are actually governed by the federal government, and they're reassessed for compliance to that program every 3 years. And actually, sliding fee discount is one of the key 19 program areas they have to comply with. So anyone under 200% of the federal poverty level must be offered a discount. And if you are 100% or lower than the federal poverty level, you have no payment. So you have to slide that scale all the way to 0. So that is really important. And we have been very concerned about this bill. Of course, we support access to care. That's what we work for every day. However, we were concerned that adding additional providers into the healthcare safety net without a corresponding investment into the fund could really destabilize the fund for those providers that are currently receiving dollars. We have worked with the legislature, with the governor, actually several administrations, to make sure that that fund is adequate, and it has really increased in the per visit cost. I was speaking actually with one of our health centers today who was around when that fund was implemented, and she said she was getting about $17 a visit. Through the commitment of the Department of Health, health centers are now receiving about $68 a visit. That sure doesn't cover the cost of care, but when you're running a nonprofit clinic, as all of ours are, every dollar counts. So we really are just concerned about protecting that, and certainly agree with the comments that we would love to talk with the Department of Health and other stakeholders about this and see how we can get care to more uninsured Tennesseans without destabilizing care to existing providers.
Thank you. Representative Hemmer, you have a question?
Thank you. Appreciate your testimony. Curious about how much of your funding is federal versus state.
You know, it really varies by clinic. So our health centers, even though they do have a standard of these program requirements and compliance elements they must meet, they're all community-based organizations. So they're all 501c3s. They actually have a board that has to have 51% actual patients on the board. So it really depends on the area that they're located in, how large their health center is. So it's hard to answer that question. We can certainly get some averages and get that back to you if that'd be helpful.
For the 22 counties that don't have or not served by FQHC, why is there not one in those counties, and what can be done about that?
You know, I occasionally will get calls from organizations interested in starting an FQHC in those counties, and we've worked with them over the years. I will say the bar is fairly high to start an FQHC. You also have to go through a competitive grant process with the federal government. So sometimes perhaps some of those applied and were not funded, or another barrier presented itself. But we would love to get more health centers in those areas.
Is there any state funding for to start up these, or have been presented?
No, sir.
Okay, I think TennCare's got $703 million left over if you need any.
Thank you.
Chairman Sapicki.
Thank you, Madam Chairman. So you said the increase went from $17 a visit to $68 a visit. That's correct?
Yes, and that's over about well, that's since about 2005 or 6. So it's been a pretty long period of time.
Chairman Sapicki.
And not to beat this dead horse, but if we could invest more money into the safety net for incentivization of these providers to get involved, and we needed money, we possibly could have taken it from the $700 million that got sent back to the general fund to balance our budget. So maybe we can do a better job this year on that surplus and maybe earmark it to expand more rural health care in our counties that don't have it. So thank you for your testimony.
Sure. Thank you. Any further comments or questions? Seeing none, thank you for your testimony.
Thank
We're now
you.
back in session. Chairman Martin, you're recognized.
Yeah, thank you, committee and chair, again, for listening to that dialogue. I believe that it's something we all need to hear and work through and process. And I appreciate the speakers coming and speaking on that behalf. I want to officially take this one off notice for today, though, and we
Okay.
will work on a solution as we move forward.
Thank you. Without objection, House Bill 1985 has been taken off notice. Item number 7 is House Bill 2076 by Chairman Martin. It's been rolled 3 weeks. That concludes our calendar for the day. Before we close, are there any announcements? Do I have a motion to adjourn? We are adjourned.